Hello everyone, my name is Janatowna. Today's topic is topographic anatomy of the upper limb. We start with the regions of the upper limb. There are 16 regions. First is deltoid, number 2 is clavipectoral, number 3 is pectoral, number 4 is scapular, number 5 is axilla, number 6 anterior arm, number 7 posterior arm, number 8 is cubital, number 9 is posterior elbow, number 10 is anterior forearm, number 11 is posterior forearm, number 12 is anterior wrist, number 13 is posterior wrist, 14 we have our palm, 15 we have dorsal side of the hand, and 16 we have our phalanges. There are 3 complex joints that form the shoulder joint. We have our sternoclavicular joint, acromioclavicular joint, and glenohumeral joint. Now we're going to talk about glenohumeral joint. Glenohumeral shoulder joint is a synovial ball and socket joint that allows wide range of movement. However, its mobility makes it unstable. The large head of the radius articulates with the shallow glenoid cavity of the scapula, and it deepens with the fibrocartilaginous ring-like shaped glenoid labrum. Fibrous capsule surrounds the shoulder joint and attaches superiorly to the margin of the glenoid cavity and inferiorly to the anatomical neck of the shoulder. Fibrous capsule is reinforced by the ligaments, coracohumeral ligaments and glenohumeral ligaments, and also rotator cuff muscles. The shoulder joint allows movements in 3 axes: flexion, extension, abduction, adduction, medial rotation and lateral rotation, and circumduction. It is innervated by the axillary, suprascapular, and lateral pectoral nerves. It receives blood from suprascapular, anterior posterior circumflex arteries, and scapular circumflex arteries. Now we're going to talk about rotator cuff muscles. Rotator cuff muscles consist of tendons of 4 muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. Rotator cuff muscles stabilizes the joint by keeping the head of the radius articulating with the glenoid cavity of the scapula. It also fuses with the capsule. Now we're going to move on to the elbow joint. Elbow joint is a synovial hinge joint that consists of humera radial and humera ulnar joints, allowing flexion and extension. It also includes radia ulnar, proximal radia ulnar pivot joint that allows the head of the radius move on to the ulna, the radial fossa of the ulna, and allows supination and pronation. The elbow joint is innervated by the branches of musculocutaneous, median, ulnar and radial nerves. It receives blood from brachial artery, radial artery, and ulnar artery. The ligaments of the elbow joint are collateral radial ligaments, collateral ulnar ligaments, and annular ligaments. Now we're going to talk about brachial plexus. Brachial plexus is a complex of nerves that supply the skin and muscles of the upper limb. It's subdivided into roots, trunks, cords, cords, and branches. Now I'll show you the easy way to draw the brachial plexus so it's easy to remember for you. Okay, so we start with 2 lines, 2 horizontal lines. We'll draw one here and one here. Then we draw the intermittent line in the middle like that. Then I have my X on the upper side. Then I have my Y in the lower side. Now this branch goes and subdivides into 2. And we have here the axillary nerve and the radial nerve. Okay, now you have our M. Okay, so this is our skeleton. This is our musculocutaneous nerve, median nerve, and ulnar nerve. So this is the basis of the brachial plexus. Now we're going to name the roots, okay? So we start with C5, 6, 7, 8, and T1. Okay. I'll draw the little branches from the brachial plexus. Here we go, the dorsal scapular nerve, suprascapular. Okay, here we have two pectoral nerves. One is lateral pectoral nerve and one is medial pectoral nerve. And together they connected to supply pectoralis major muscle. Okay, we have three branches coming out of here. We have upper, middle and lower subscapular nerves. The medial one called thoracodorsal nerve. Okay, here we have our two branches, medial cutaneous nerve of the arm, medial brachial nerve, and medial cutaneous nerve of the forearm, medial antebrachial nerve. Okay, another long nerve that comes off C5 and C6 and C7. C6 and C7 is a long thoracic nerve. Okay, now we're going to move to anatomical snuff box. Anatomical snuff box is a triangular shaped depression on the dorsum side of the hand, and it's visible when you stretch your thumb. It's called anatomical snuff box because in the past people used to put the tobacco on the depression and sniff it through the nose. That's why it's called snuff box. The borders of the snuff box, we have radially abductor pollicis longus, in the middle extensor pollicis brevis and extensor pollicis longus. On the roof we have the skin, and on the floor we have our carpal bones. We have we have a scaphoid and trapezium. Okay, and on the proximal side we have a styloid process of the radius. The clinical importance of the anatomical snuff box is the scaphoid fracture. The scaphoid bone is the most commonly fractured bone in the hand, normally when people fall on the outstretched hand. The worry is the concern when the scaphoid fracture happens because of its retrograde blood supply, which comes from the distal part. If this fracture is in the middle, the proximal part of the scaphoid bone becomes avascular. So that's why we say avascular necrosis. People who miss the scaphoid fracture, they get osteoarthritis in later life. Next, we talk about the forbidden zone of the hand by Canaval. The forbidden zone in the surgery, it explains like that. When the median nerve exits the carpal tunnel, enters the palm of the hand, it gives branches, lateral branch, to the thumb of the hand. The point where it gives branch is called the forbidden zone, due to the fact when you make the incision in that zone, if you make a damage, the nerve affects the motor function of the thumb and makes it dysfunctional. That's why I call it the forbidden zone. It projects, the zone projects in the proximal third of the eminence muscles. Okay, now we have 3 questions for you after this lecture that you need to answer. The first one is, which nerve is damaged as a result of the dislocation of humeral joint? Number 2, what is the result of the damage to upper parts of the brachial plexus, C5 and C6? And number 3, nerve of which damage leads to this condition, the condition on the picture? I'm going to give you some time to think about it. And the answers are, number 1 is axillary nerve. Number 2 is Herb Duchenne's palsy. And number 3 is long thoracic nerve. Thank you very much for your attention. Good luck with your studies.